Good afternoon, everyone. Thank you for joining us on this cold and icy day. Today, we are joined by Christina Brent and Dr. Sarah Coffey. They're both in the Psychiatry Department here at Oklahoma State University Center for Health Sciences, and they will be sharing information and resources available through the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program. We are a smaller group today, so if you have any questions, please feel free to unmute your line or put something in the chat, and I will be watching the chat, Christina and Dr. Coffey, to let you know if we have any questions or anything that comes through. So with that said, if you're watching this recording, please do not hesitate to reach out with any questions or concerns. With that said, Christina, I will turn it over to you.
Thank you so much, Laura. I really appreciate it. So my name is Christina Brent. I'm the clinical director for the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program, or OKCAPMAP for short. Today I'm going to speak briefly just at the beginning of our hour about OKCAPMAP, how we came to be, the reason we felt this type of program was important in our state to help meet pediatric mental health needs. We're also going to hear from Dr. Coffey. She's going to speak a little bit on the topic of ADHD. We also have with us Raquel Haas. She is our coordinator for our program, and she is going to be kind of as we're going through, she's going to be dropping some stuff in the chat, some links and some resources that we're going to briefly talk about. So to get started with my portion of the presentation, I want to start with a little bit of data, because who doesn't love data? And then just a little bit of a history lesson about the type of program that we are, and then I'll hand it over to Dr. Coffey. So the need, this is kind of where our backstory begins. So increasing access to child psychiatry and mental health services, specifically for the state of Oklahoma. So for our state, all of the research studies, all of the data points for Oklahoma, we tend to be at the bottom of the ones we want to be at the top of, and we tend to be at the top of the ones we want to be at the bottom of. And when we consider pediatric mental health, there's a very large need in our state. So our process started in 2021. And so the data that we're going to be looking at is from 2021. And that's where that backstory and that need was really highlighted for how our program came to be. So in 2021, we ranked 46th for youth with a higher prevalence of mental illness, 33rd for access to care. At the same time, we were categorized as having a severe shortage compared to the rest of the nation for child and adolescent psychiatrists. We were averaging about 7 child and adolescent psychiatrists per 100,000 kids. And when we break that number down even more, it's about 14,000 to 1. And then our youth suicide rates at that point in time in 21 had increased 103% in the last 14 years, compared to only a 42% increase nationwide. And suicide remains the second leading cause of death for ages 10 to 24 in our state. We also look at poverty. It's a known social determinant for both physical and mental health, which puts many of Oklahoma's children at risk because the poverty rate, especially in our rural areas, is really high. Almost 18% compared to almost 14% for those urban to rural areas of the state. Another big piece of data that we looked at is the Oklahoma Department of Mental Health and Substance Abuse Services. Every odd numbered year, they conduct the Youth Behavior Risk Survey. So it was really convenient that 21 was an odd year. So we were able to get very fresh data. So for those who might not be familiar, the Oklahoma Youth Risk Behavior Survey, or the YRBS, is part of a larger youth risk behavior surveillance system that includes a national school-based survey conducted by the CDC. It also includes information from states, territorial, tribal, and local surveys conducted by those agencies and tribal governments, health agencies and tribal governments. So the Youth Risk Behavior Surveillance System monitors 6 types of health risk behaviors that contribute to the leading causes of death and disability among youth and adults, including behaviors that contribute to unintentional injuries and violence. sexual behaviors that contribute to unintended pregnancy and sexually transmitted diseases, including HIV, alcohol and other drug use, tobacco use, unhealthy dietary behaviors, and inadequate physical activities. So the Youth Risk Behavior Surveillance System also measures the prevalence of obesity and asthma among youth and adults, and the YRBS that we focused on, it's a randomized statewide survey. The data represents public school students in grade 9 through 12 in Oklahoma. So every odd year, the spring of every odd year, 50 schools public schools from around the state are chosen at random to participate in this survey. And what we did with this 2021 information was pull out those significant factors related to mental health, specifically suicidality. So what you see here is that in 21, about 43% of 9th through 12th graders that were part of that 50 school sample reported over the past year that they had experienced sadness or hopelessness. About 23% said that they had experienced suicidal ideation. About 17 to 18% said that they had suicidal ideation with a plan. About 10% made an attempt on that plan. And about 3.5% to 4% of those attempts resulted in injury or death. And we also looked at the national average for those under the age of 18 who presented to an emergency room or emergency department for a psych-related situation. We averaged the monthly encounters by year to see the overall year-over-year trend for crises presenting to an emergency department. And so what we see here is that we had a steady incline, a little bit of a dip in 2020. Thank you, COVID pandemic. Everyone was quarantined. We had lockdown. Not a lot of people were leaving the house. If it wasn't something to seek out medical care, if it wasn't something COVID related. So there was a lot of underreporting that happened during that year. But as soon as the lockdown lifted and people started leaving their homes, you see we hit that steady incline again, and it has just continued to climb since then. So the need is definitely there. But what can we do about it? Well, we can start the conversation, but then who's responsible for that conversation? So when we look at this slide, when asked who should start a conversation about a child's mental health during a primary care visit, families replied with the following. So about 36% of families that were part of this study or survey said that the doctor's got to bring it up. If it's not on the doctor's agenda, then we're probably not going to discuss it. About 29% of families said that it should be the parent or the guardian who brings it up. About 15% said parent or doctor. About 12% said anyone concerned. It doesn't matter who. If there's a concern, anyone can start that conversation. About 8% said the nurse. So I'm guessing that maybe through some sort of like triage, how you usually answer all of the questions with the nurse before the doctor ever enters the room, it should be included in those questions. So what this tells us is that at least 45% of families will more than likely never start a conversation about their child's mental health whenever they see the primary care provider. So in order to help fill this gap, in 2021, a group including TriWest, Healthy Minds Policy Initiative, the Oklahoma Department of Mental Health and Substance Abuse Services, and Oklahoma State University Center for Health Sciences applied for HRSA funding to develop a pediatric mental health care access program, or PMHCA, for Oklahoma. And I love this quote from HRSA. It's that the mental health need for children and adolescents is rising across the nation. The Health Resources and Services Administration, or HRSA, is trying to help the need by helping support states to start child psychiatry access programs. So you might hear me say PMHCA or CPAP. Those two terms or acronyms, those are synonymous with one another. And that is the type of program that we are. We are a child psychiatry access program. We are a pediatric mental health care access program. So some more history. Access to child psychiatry has been a significant problem nationwide for years. It was documented in the Surgeon General's report as early as the year 2000. Increasing prevalence of child behavioral health issues coupled with a stagnant workforce has only made the situation worse. And children's primary care providers have ended up meeting this need, even though they might not be prepared to do so. So in 2003, a pilot program was developed at the University of Massachusetts Medical School in Worcester to provide psychiatric consultation to pediatricians. This was enthusiastically supported by the Massachusetts chapter of American Academy of Pediatrics Mental Health Task Force. And in 2004, the Department of Mental Health and Massachusetts Behavioral Health Partnership adapted the model to be implemented statewide. Things went really well. A lot of research was published, big successes were happening. And in 2011, a core group of national leaders dedicated to pediatric and child psychiatry established the National Network of Child Psychiatry Access Programs. And that continued to do really well. And in 2014, it became incorporated as the National Network of Child Psychiatry Access Programs, or the NNCPAP. And we are a part of that organization. And one thing that's really cool about this organization is it will take those older programs and they will serve in kind of a mentorship role for younger, newer programs. So we were first starting out, we were able to seek out a lot of mentorship. And now that we have become more established, there are programs that are younger than us that are actually seeking out mentorship from us. And that's been a really great experience to be able to kind of pay it forward in that way. So when we started the process, this is an old map. I'm trying to find an updated one. But when we started the process, this is kind of what the map looked like. And then in 2021, we got our funding. That's why we're in green. It's outdated because now the only state that does not have a PMHCA is Idaho. Not sure what's going on with Idaho, but they're still the only state that does not have a PMHCA. And there are also some of the U.S. territories. I had to go back a spot for a note, sorry. So some of the U.S. territories are also included, and then a couple areas up in Canada are also have PMHCAs now. So when we got this funding in 2021, we decided that we would, all of the funding came through, and we were formed with the mission of specifically provider to provider support. So our overarching goal is to maximize the number of medical providers in Oklahoma receiving support for their care of infants, children, and adolescents with psychiatric and mental health needs by providing real-time pediatric psychiatry and mental health consultation. We also offer enhanced psychiatry and mental health education and training. And we have created and are maintaining a statewide infant, child, and adolescent mental health services and support referral database. And we use these 3 buckets, is what we call them, to assist with minimizing barriers and accessing mental health care for pediatric patients. So when it all started for us, we decided we needed a statewide advisory committee, and we also did a statewide provider needs assessment. So the provider needs assessment ran from December of 21 to May of 22. Those who participated in that needs assessment are these orange dots on our map here. So we had about 30% that were in that Oklahoma City metro area, not quite 24% that were in the Tulsa metro area. And then the bulk of our responses, we really wanted to be focused in that rural Oklahoma area. And then we had just over 200 responses, so just over 200 providers responded to our needs assessment. And the information that they shared is that about 89% of them needed help with referral assistance. About 80% of them really needed help with that psychiatric consultation, that medication component. These are big medications and big diagnoses. And my training didn't cover all of this specialty work. So having a specialist who can help would be really helpful. And then education for the providers themselves and for their support staff were those 4 main areas where we received feedback for the most help being needed. We also had 20 primary care providers that did a more in-depth interview with us, and their feedback was medication consultation beyond initial evaluation, developmental and complex diagnosis education. So you've got kids coming in with 1, 2, 3, 4, 5 or more big diagnoses. How do we support these, and making sure that we're having appropriate interactions, not maladaptive ones? Referral assistance. We've got a lot of areas in our state where there are just not a lot of resources, which is where our database is really helpful. And then medication management with post-discharge care. A lot of the feedback that we were receiving was this kid was just discharged from inpatient, and they came with a list of medications. Some of them I've never even heard of before. Some of them I didn't even know could be prescribed to a kid this young. I'm nervous about moving forward with refilling these. I really need someone to talk to. That's where we can step in and help as well. And then, of course, in mental health, we love to ask that magic wand question. So if we could wave a magic wand and your wish list could be fulfilled, what would you want? And they said in-house psychiatry, in-house counselor, and in-house case manager. So with all of this information, we took to our next step planning, and we put direction on these 3 components, or these 3 buckets that we fill. So mental health education, mental health referral, and consultation. And one of the main resources that we use throughout our consultation process is the Oklahoma Pediatric Psychotropic Medication Resource Guide. We really like long names, but this is frequently shared, and we're really proud to be associated with it. It was developed in late 2019, early 2020. It is in the process of being updated, and so we're hoping to have an updated version out later this year. If you scan this QR code, it takes you to a digital PDF that is just a really great resource to have. And we can also drop the web link to this in the chat. Raquel, I don't think I had you prepped for that one, but we can make sure we get that in the chat before the end of our call. And then just a couple more slides. To date, we have 467 providers that are registered with us, representing 255 practices across 46 counties. 10 of those are urban, 36 of those are rural, and 42 are underserved. And we've completed almost 700 consultations. Our consultation line went live in October of 2022. Our amazing data person, Dr. Micah Hartwell, put together a manuscript for us at the beginning of last year, and that's what where this data is from everything that he compiled for that manuscript. So at that point, and we are getting that updated as well. So at that point in time, the majority of our consultations, at over almost 55%, were kids who have more than one diagnosis. So a lot of times that was ADHD or it was autism or it was A and B, or whatever it might be. Second to that, lots of consultations regarding ADHD, lots of consultations regarding anxiety. That other right there is primarily intellectual disability and developmental disability. Whenever this data was pulled, we didn't have a way in our system to kind of isolate that as its own data point. We do now. So when we get this updated, we will have that with its own representation as well. And this is the team. This is the way that all of this works. So I always like to include these names here. We have Dr. Sarah Coffey, who you're going to hear from in just a moment, who is our medical director and our clinical director. Our program director is Amanda Sellers. She's also a licensed mental health professional. So whenever a provider calls the line, they're either going to speak with me or with Amanda. So you're going to get a licensed mental health provider from the jump on the call. And then anything that falls outside of what our level of expertise can help support you with, that's where we loop in one of our child and adolescent psychiatrists. And we have Dr. Coffey, Dr. Swapna Deshpande, and Dr. Ose Wycliffe, who are all 3 board-certified child adolescent psychiatrists, and they rotate on call with us. We also have our referral and resources coordinator, Raquel Haas, who is the one who maintains that amazing database with I would think we're at 2,300 resources across the state. In all 77 counties, we have resources that we can share. Our data manager, Dr. Micah Hartwell, and our department liaison, Jessica Johnson, she helps us with anything university-wide that we can't figure out on our own. This is how to contact us. So our consultation line is available Monday through Friday, 9 a.m. to 5 p.m. We are closed for university holidays, but there's our phone number, our website, and our email address. This QR code takes you to our website. And then just before I hand it over to Dr. Coffee, I want to hit on two things really quick. We are doing another provider survey. This one is specific to those who work in an emergency setting, so an emergency department or an adolescent urgent recovery center. So if you're working in one of those areas in any part of the state that is supporting those emergency mental health crisis things that are happening, we would love to have you scan this QR code. We can also drop this in the chat. I think Raquel's got that ready. We do have an incentive for completing this survey. And so we would really love to hear feedback from those who are providing those emergency crisis support services to you throughout the state. And then we have our third annual Bridging the Gap conference that's coming up May 2nd. We're going to be co-hosting this with the Chickasaw Nation this year. So they are one of two tribes within the First Nation tribes within the U.S. who are PMHCAs. And so they have a program that is similar to ours as far as funding goes, but different as far as the way that they operate within the Chickasaw Nation. We're going to be co-hosting our conference this year, and we're really excited about that. Our registration link is live. So if you scan this QR code, that takes you to our registration link and our landing page, and you can get additional information about that as well. And now I'm going to hand it over to Dr. Coffee, and I can advance your slides if you want me to, Dr. Coffee.
Yeah, no, that sounds great, Christina. Thank you. And thank you guys so much for taking time to be with us today. I'm Sarah Coffey. I'm the medical director, and also really appreciate you guys joining us this afternoon. I would just kind of emphasize too, so even as a child psychiatrist and as a medical director, I too sometimes call the line. Christina has a wonderful array of resources for my own patients or even family friends to kind of know real specifically how to make a referral is just so helpful. I'm sure many of you all have been on the end of that as well, where you have somebody coming to see you and there might be an underlying anxiety or ADHD or something else going on, but we don't really know where to refer them to. Quite often in mental health, it's a blanket referral, which for families can be real challenging. And when we look at the literature too, what we notice is that quite often if that referral isn't made, or if it's not a really great referral because it's not necessarily meeting the need, not only do we miss the opportunity to provide evidence-based care, but it also makes it less likely that people will actually seek out services. And so would just offer to you, I think, a really important aspect of what we do is to kind of help right-size those referrals for you and for the patients that you're serving. As mentioned, this is going to come from our resource guide. We're updating it. We're really excited about it. And as we talked about quite often, many of our referrals are for ADHD. You all probably see this too. It's not uncommon that comorbidity is the rule rather than the exception. But one thing for sure, we know whenever ADHD is diagnosed that there's a lot of efficacy for the medications that we use. And so if there is an underlying diagnosis of ADHD, quite often being able to prescribe the appropriate medication and resources in place can be very helpful. So we thought we'd start with this as well. And Christina, if you want to go to the next slide. So again, just to kind of organize ourselves a little bit here, if you've had the chance to look at our resource guide, we really do start off with some clinical pearls for our diagnoses. We're going to be talking today about ADHD for kiddos age 6 to 17, but we also have at the beginning of our resource guide recommendations for kids age 3 till 5. And so certainly you all know this too. There's differences between ages in our pediatric population, and there's different ways to approach this as well. We see ADHD be a very common neurodevelopmental disorder that is presenting to the outpatient setting. You've probably seen this as well. And we recommend that if ADHD is presenting, we want to make sure that we're screening for trauma. Unfortunately, here in Oklahoma, as Kristen mentioned, it's not uncommon that we have a lot of pediatric patients and grown-up patients as well that are exposed to adverse childhood experiences and trauma. And quite often kind of externalized or internalized behaviors can be due to adverse childhood experiences or trauma that's happening in the home or in other places. And so we want to make sure that we're screening for that. Next slide. It's also important, and again, I think we're preaching to the choir here as well. You guys know this as primary care providers, that we are looking at other potential causative factors that could be contributing to behavior problems in younger children, whether that be seizure, elevated lead levels, vision or hearing problems, thyroid, hepatic, substance use, etc. This is why I do think it's so important, as an adult psychiatrist, but also as a child psychiatrist, the primary patient-centered medical home and pediatric providers play such an instrumental role when it comes to behavioral health concerns. Many of you all are folks that you're working with, perhaps even cared for the parents or caregivers of young kids. I can't stress enough just the importance of our primary care teams in helping to identify and to treat behavioral health disorders, because parents and caregivers and the communities really rely on you all as trusted providers. And so certainly making sure that we're looking at all of those potential factors that could be contributing. We'll show here in a bit too some free rating scales that you can use whenever you're making the diagnosis. Certainly we want to make sure that we're screening for other things that be contributing, but also make sure that we're kind of doing our diligence to get an accurate diagnosis from the DSM-5. The Vanderbilt and other rating scales can be used to make sure that we're kind of ascertaining that there is some functional impairment both at home and in the school or daycare setting. Next slide. Other clinical pearls, you guys probably see this too. We know that learning and language problems can be common comorbid conditions with ADHD. And again, if a diagnosis is unclear, we can certainly refer for psychological testing. What I'll offer to you too, just to kind of loop back in OKCAPMAP in this realm, we also offer guidance on that. So if you're not quite sure, is this child meeting criteria for ADHD or not? What do I need to do? Give us a call because Christina, myself, and our colleagues can walk you through that and maybe see if there's something else going on, a learning disorder, perhaps anxiety, or maybe something else you're not thinking about. Again, as a child psychiatrist, we're often taught about the importance of peer supervision and consultation. Quite often, I'm calling my CAP colleagues or others just to kind of ask, does this seem right? Is this what's going on? We want to be your trusted phone-a-friend, so feel free to give us a call if you have any questions. The American Academy of Pediatrics and others really do feel strongly that uncomplicated ADHD should be able to be diagnosed and treated in the patient-centered medical home. We know this can be a challenge too. So often our primary care docs and clinicians are really busy doing very quick, kind of visits and being able to meet the need of the community. Again, we're there to help to support you to kind of help make sure that you have a great diagnosis and adequate treatment to be able to help support these kiddos coming to see you. Next slide. When we think about first-line treatments, and again, depending on, I'd say, what organization you're looking at, there can be a little bit of differences here. When we look at the studies, and a lot of this has been done in the field of child psychiatry, really medication for treatment of ADHD has some of the highest efficacy compared to everything else that we do in child psychiatry. So more often than not, there will be a recommendation for medication. That's not necessarily true for our littles, for kids age 5 and younger. We just had a call earlier today, and we talked about that really first line treatment of kids age 3 to 5 includes a behavioral therapy that includes the caregiver for step 1. And if that doesn't work, trying another behavioral therapy and then going to medication. Ages 6 to 11, we often do recommend an approved medication alongside behavioral therapy, something like parent management training. And then age 12 to 17, again, an approved medication and behavioral therapy if insufficient response. And what I'd offer here too is I think probably more so in child psychiatry in particular, quite often, the first step is going to be behavioral therapy, including the caregiver, especially if the child is younger. ADHD is probably the only diagnosis that we would say, we're not as strongly kind of supporting the use of therapy because medication can be so helpful. Doesn't mean that we don't involve therapy in the picture, but just to offer that medications can be extremely helpful in making sure that we are treating ADHD symptoms. I think one of the biggest things too, so often I think that ADHD symptoms can be more problematic to those that are caring for the child than perhaps the child themselves. And so it's not uncommon that there might be an insufficient response to treatment. And so really making sure that we are adhering to medication can be very helpful, especially with our stimulant medications. Quite often you're going to know right away if it's going to be helpful or not. It might be because it's not the right medication or the right dose, but we want to make sure the child's actually taking the medication. I can't tell you how often I've had family members that, once they're moving, they find the medication under the dresser. And so really making sure that we're having those conversations with kids about that the medication should be treating the symptoms, not changing who the child is or kind of causing them to be a zombie or something else that's going on. We really want to make sure that we're treating the symptoms without having any adverse effects. And one thing that I say too to families and to the youth as well is that if the medication is causing you to not feel well or not feel like yourself, if you're having any problems with it, then it probably isn't the right medication for you. And so we want to make sure that we're having open conversations with the youth and the caregiver to make sure it's the appropriate medication. Next slide. When we look at effectiveness, and again, this just kind of goes to, I think, why medications are often a first line for ADHD treatment, is that really stimulants overall have some of the strongest efficacy for supporting of ADHD symptoms. You can see here the effectiveness of 1.0. Further down, atomoxetine or Strattera is at 0.7, and then guanfacine, kind of the alpha agonist, is at 0.65. The way that I was always taught too is kind of thinking about in treatment of ADHD, we know there's a combined type. We know there's inattentive or there's hyperactive. Stimulant medications can be extremely helpful in treating kind of both sides of the inattentive and the hyperactivity. Atomoxetine often gets a little bit more coverage of the kind of inattentive ADHD, and then guanfacine perhaps more so of hyperactivity. Doesn't mean that those two, atomoxetine and guanfacine, don't cover the other side, but kind of thinking strategically about which one you might use. Again, atomoxetine probably more so helpful for kiddos that are inattentive type ADHD, and that perhaps there's an underlying anxiety. Guanfacine perhaps more helpful for kiddos that are more hyperactive, but that stimulant medication really does have coverage for both. Next slide. What I'd offer too is, something that often comes to mind, and it's something that we're looking at more so with this updated resource guide, is what about other treatments or interventions that can be helpful. There's a lot of talk about certain clinics that will do images like EEGs and others to see if that can help with diagnosing of ADHD. The reality is that those aren't really ready for prime time yet. There's not a lot of evidence to support that those can be helpful. What I'd offer too, that doesn't mean that in the future they might not be helpful, but right now we don't use imaging to diagnose ADHD for children. Omega-3 or 6 supplementation, there isn't a lot of great evidence. There is some minimal evidence for treatment of like micronutrients for the more irritability side of ADHD. But these aren't necessarily commonly used in practice. And quite frankly, the couple of things about it is that the FDA continues to not kind of look at and approve these types of medications or supplements, and they're not necessarily covered on insurance. And so I know I have some colleagues that might use micronutrients or suggest micronutrients to kind of treat the irritability, but oftentimes folks are paying out of pocket, and it's often a lot of micronutrients that they need to ingest in order to really meet those symptoms. In our current climate too, there's a lot of conversations around elimination diets and other things that might be helpful for kids. I think that as a true physician, as scientists, we always want to be curious about that. A way that I approach that too, like if family members are telling me, that they're, removing red dye or doing something else, and it seems to be helpful. I think that's great. If we find that there is no harm done, and folks are noticing an improvement, I think that's very impactful too. We know that sleep and diet and exercise and everything else can be very helpful, not only for our kind of physical health, but also our behavioral health as well. Certainly want to promote that. But I'd say not throw the baby out with the bathwater, that all of these things can be part of a holistic caring for individuals that have ADHD. And so we want to be thoughtful about the best way to move that forward. The other thing that isn't included in this slide deck, but is also available to the FDA, and I might have to send this out to you later unless Raquel can find it. Raquel, you might want to look at the FDA kind of approval for ADHD treatment. There's actually an app or a game that's now FDA approved for the treatment of ADHD. And so you might have families that don't want to do medications. I think kind of landing on the FDA approval can be very helpful to kind of consider other supports. But a lot of this is just emerging evidence that's coming on board. And I think important for all of us as physicians and clinicians and caring for kids to make sure that we're using best practices in our treatment. Okay, moving forward, next slide. As I mentioned, all of our kind of diagnoses in the resource guide are going to have some rating scales that are non-proprietary, i.e. free for you. We think this can be very helpful. As you guys probably know, whenever we're making a diagnosis of ADHD, we really should see symptoms present in more than 2 settings. So both in the home as well as in school or as in daycare in order to make that diagnosis. Certainly there might be more, I'm going to say, cognitive demand in the school setting. So we might see an exacerbation of symptoms, but you really want to make sure that we have those symptoms that are present in both and to make sure that we're having that diagnosis. As you can see here, we recommend using the Vanderbilt, or the Conners can also be used. There's also the prodromal questionnaire brief version. And as stated, the Vanderbilt can be used there as well. And all of these have hyperlinks in the resource guide if you scan it and find it online. Next slide. So there can be certain ways to kind of think about the pharmacotherapy and treatment approach. I'd say, I want to use the word purist, but I don't know if that's the most appropriate way to describe it. But some folks might say that really, regardless if there is underlying anxiety or even hypertension, it's not super common in our pediatric population. And quite often we find that kiddos actually respond quite well to these medications. They might recommend starting with a stimulant medication because the effectiveness is so strong. But you could certainly see perhaps if there is comorbidity, another way to kind of do this pathway. And so we'll start first with just kind of pure ADHD symptoms. So if you have a child that's coming to see you, and they have an underlying diagnosis of ADHD. You've done a great screen. You don't see any trauma or any comorbid psychiatric diagnoses. Quite often, we're going to recommend starting with a methylphenidate or an amphetamine salt preparation, and then kind of moving forward in that realm. I think probably the most helpful thing about our stimulant medications is, again, we do know quite readily if it's going to be helpful or not. In child psychiatry, oftentimes the motto is start low and go slow. I'm a big believer in the lowest possible dose that really improves treatment is going to be what I'm going to go for. So rather than trying to get to a max dose that I'm pulling down from the literature, I want to make sure that I'm meeting the individualized child's needs. And so I often do start quite small, typically with a methylphenidate preparation, and then titrate to kind of see if there's going to be some improvement. The recommendations, if there's other non-contributory factors, if you've kind of gone through the methylphenidate route and things haven't been, there hasn't been an improvement in symptoms, or perhaps the side effect profile was too much, then switching to the amphetamine salt. It's not uncommon that we see this in practice too, that you might have a kiddo that couldn't tolerate a methylphenidate preparation, and perhaps because there was some irritability or something else that was going on. That doesn't necessarily mean you're going to have the same effect if you do another stimulant in a different class. And so quite often we do recommend trying something like an amphetamine salt, an Adderall, or a Vyvanse to see if there's going to be some improvement there too. And again, always kind of titrating to treatment response. We often recommend resending out that Vanderbilt to the family or to the school to kind of make sure that symptoms are getting better. If a child does have hypertension, you might consider not using a stimulant medication. And so you might use an alpha agonist, something like clonidine or guanfacine, again, to kind of see if that's going to be helpful. And then again, titrating to the kind of treatment response for this as well. Or you could certainly consider using atomoxetine or Quellbry or another medication that isn't necessarily in that kind of stimulant class. And then there are recommendations if there's underlying anxiety disorders or perhaps active substance use, specifically in our older teens or populations in that realm. Atomoxetine might be helpful in that regard as well. So again, in all of our kind of diagnoses, we have this kind of algorithm to think about the best way to treat moving forward. And we'll go to the next slide. So as you can see here, just kind of going forward, we have stage 3 or stage 4, and perhaps not too surprising. We're just going to kind of try different medications from a different class to see if it's going to be helpful. I will say too, just to kind of add this as well, in most of child psychiatry, there's really not a lot of evidence to support polypharmacy for the treatment of an underlying diagnosis. So unlike we might see like in an adult population for depression, where you might use adjunctive therapy to kind of treat the underlying depressive disorder, not a lot of evidence to do that in our pediatric population, except for perhaps in the treatment of ADHD. And so there is some evidence because we know what is often is a rate-limiting step in the treatment of ADHD symptoms is that you might have a little guy that has, let's say, combined type ADHD, and you're starting them on a stimulant medication, and it's been pretty helpful. But because of perhaps appetite suppression, or because perhaps whenever it's too high of a dose of the stimulant, there's a little irritability there, you're kind of getting not fully into remission, and you're having to stop, let's say at like 5 milligrams BID or Concerta at a certain kind of extended release. There is some evidence to support that the addition of an alpha agonist, something like guanfacine or Intuniv, with the stimulant can actually be quite helpful to kind of manage all of those symptoms. And again, this is something that we often hear, like whenever we're consulting, that you might give us a call and kind of ask about, and might be one of our recommendations to see about getting that treatment response. Okay, next slide. So this is just another way of kind of thinking about the dosing parameters. This comes from pediatric psychopharmacology for treatment of ADHD and others that was in pediatrics. Quite often folks ask me, what stimulant medication am I going to choose? More often than not, I feel like we're often beholden to kind of the tiered support of the medication. And honestly, that's okay. They're really doing much of the same thing. And so kind of starting there can be very helpful. Again, quite often we are using kind of an immediate release first to kind of titrate to that specific dose that we're going to need before we switch to the extended release. You don't necessarily have to do this in this way, but certainly the younger the child, the more likely I'm going to use the immediate release to make sure that I'm getting both the right medication as well as the right dosage and the right timing. That's another thing that I'd offer too is that certainly what we find is that parents, teachers, educators, those that are involved with the kid know when the medication is on board and when the medication is kind of wearing off. And so it's really helpful whenever family is coming back to see you, that if they say, oh, the medication is working, but it's not working sometimes, tell me when that sometimes is, because that really helps me to kind of know when perhaps the medication is wearing off. You all know this too. I think our pediatric population are metabolizing things so quickly. It's not uncommon that I sometimes even am prescribing Vyvanse in a BID dosage because although it is an extended release medication, it's only lasting for 4 to 5 hours. And then by lunchtime or early afternoon, it's wearing off again. So just really looking at the individual and kind of making sure we are targeting the appropriate kind of timing for treatment of ADHD symptoms. Next slide. This is just another representation of kind of the initial dosing and the maximum recommended dosage. Again, there are several medications that have availability either in an oral solution or perhaps a chewable tab or a transdermal patch. I think a lot of that is going to be kind of dependent on the individual, which one you might choose. Next slide. So all of our resource guide has resources both for the provider or perhaps for the family. These are just some hyperlinks that you'll find in the resource guide that can be helpful for you or for the family members. Next slide. And just some more resources that are there. Next slide. And then these are some references that you can see that we pulled from. And Christina, if you want to pass through the kind of references, we'll go to the case.
Yes. So one of the things that we wanted to do, thank you, Dr. Coffey. One of the things that we wanted to do was provide a couple of consultation examples. So these are going to be real consultations that Dr. Coffey and I have done together that had a focus on ADHD as a concern and what led to the provider seeking consultation with our program with OKCAPMAP. So before I jump to that, I wanted to also say consultation is available to anyone who provides a direct service to a pediatric population. So 0 to 21 is our age range for our consultations. That's not to say that if you have a patient that falls just outside of that 21 age range, that we won't still help if we have resources available. I always like to throw that in because I am the one who's going to take the call. I don't want that to be too hard and fast on that. So we've got resources that we can share, and we want to be an available resource if the age does exceed 21. And it's really easy to get registered with us. It's no cost to register with us. I ask a couple of really basic questions. What is your name? What is your NPI? What's your preferred phone number if I need to give you a call back? What's your email address? Because every consultation that we do, we send a summary of what was discussed during that consultation call, and you'll see a couple examples of what that email has looked like for the consultations that we're going to walk through. And that's it. That's all it takes to register is those pieces. So you can register beforehand, or I can take 90 seconds to get you registered at the beginning of the phone call. So it's really easy to access us, even if you're not already registered. For this first consultation example, we had this was done May of 2023. So we had a provider call regarding a 9-year-old male, Black or African American, non-Hispanic. The information that the provider shared. So we start the call. I pull them up in our system, or I get them registered in our system, and then I say, what information will be helpful for us to know for this consultation? And then I just take notes on what they share. So this is what this provider shared. ADHD evaluation has been done within the last month. They came into the office today to discuss that evaluation and medication options. Mom had expressed concerns about impulsivity and claims that as recent as 2 days prior, the patient had said he wanted to get a gun and shoot himself. Mom believed that it was for attention. When the provider asked further, this is not the first time that the patient has had these thoughts or said these things. There have been no attempts. It seems to be kind of passive transient thoughts. The second time expressing using a firearm, which this family does not have firearms in the house. That is something that the provider had asked about. And once before, he had also said that he would stab himself. So it seems to happen when something happens that he does not like. He's never been aggressive towards himself or others, but he's very impulsive. And so that's where a lot of the concern and the drive to seek us out for this consultation came from, is because of the level of impulsivity that this 9-year-old has. No prior discussions about anxiety, depression, or any other mental health things. The provider did not ask about access to other medications in the house or other lethal means. That was something that I had asked the provider if they had talked to the family about. Just kind of an overview of we use the term considerations that were made during this consultation call. And this next slide is what was sent to the provider. So this is what we discussed during that consultation call. So we provided crisis support resources that the PCP could share with the family, including 988, their website information, their text information, and some urgent recovery centers, a couple of urgent recovery centers that were within a reasonable distance for this family. And then some outpatient counseling options, and then also some screeners that we had discussed, including the Columbia, and some handouts that with some information on lethal means access, restrictive access to lethal means within the home, and then also what they can expect from a referral to counseling, because this kiddo had not been in counseling before. And then down here we have the considerations that Dr. Coffey gave regarding medications and some of the other pieces. And I don't know if you want to kind of talk through that, Dr. Coffey.
Yeah, what I might just say too is that, I mean, this is a pretty typical call that we get, right? The reality is that our primary care workforce is really caring for a lot of kids, many of which have kind of complicated histories, many that are presenting in crisis, and our goal and role is really to help to support the primary care clinician to make really strong kind of recommendations for the family and to help them to not feel alone. I would think even if this child came to my office as a child psychiatrist, I'd be kind of calling the cavalry to kind of make sure that supports are there. And I think that's one thing that we find too, is that it allows that kind of direct support. There's also this kind of see one, do one, teach one model that we see in our OKCAPMAP line too, that once we feel comfortable kind of knowing what to do, that whenever another kiddo comes in with a similar presentation, we've been here before, I kind of know the resources to call. And so it helps not only the child and family that we're seeing in the office, but also others that are coming in to make that support. And I would just offer here too that in addition to that kind of phone call that we're doing, this is the kind of information that you'll get from our OKCAPMAP team that kind of really spells out the resources that are available. Many of our docs might even kind of print this out and put it into the medical record so that they have it there, or kind of send it to the family, but just a way to kind of make sure that consultation is there. So
yeah, thank you, Dr. Coffey. You actually hit on what I was going to say next, is that, yeah, we write these follow-up emails in such a way that it can be entered directly into whatever chart or system is used for documentation on the provider's side. But we've also had providers share feedback that they will just print this out and any attachments that we send and give it directly to the family. And we'll talk through it with them. And so everything that we do, we try to have it be as accessible and supportive as it can be, because we know that providers are really busy. They have really busy schedules, and they might not have the support staff available to kind of do some of these steps. And so we try and be helpful in that way. This is the second example that we've brought. This one was done September of last year. 8-year-old female, Black or African-American, non-Hispanic. This particular patient was living with her adoptive parents, who happened to be her grandparents. She was on guanfacine 1 milligram for a little while, but stopped it because it wasn't helpful. The family felt like there was no effect. At the time of the consultation, she was taking Adderall XR10 in the morning and Adderall 5. Towards the end of the school day to kind of help her get through that homework piece and just kind of her evening at home. No issues at school. Things seem to be okay in the evening at home. The big problem for this kiddo and for this family is the morning time before her meds were kicking in. Adoptive dad felt like the medication works great once it kicks in, but it's getting her up in the morning that is a terror, is the word that was used, until the medicine kicks in. So the provider was asking if there was something different that could be done for the morning. We discussed that this patient was already in counseling. And one of the things that we had discussed also was the sleep routine. There really wasn't one. And so that was one of the pieces that I had talked about on the consultation call, and provided some supports for developing a good sleep routine. And so the email that was sent to this provider, and not all of them are super detailed. The two examples that I happened to pull happened to be lots of considerations were given. Sometimes anything that I can help with has already been established. They're in counseling. We don't need to do any screeners. All the screeners were done. Families got great resources. It is solely a medication consultation, and that's perfectly fine. And so those consultation emails, follow-up emails tend to be a lot shorter. And then we've also had some that are 2 and 3 times this length because so much was discussed. And so this was what was sent back to the provider. We did talk about doing an anxiety screener to rule out if there was anything like a school anxiety that was a contributing factor. And my preferred screener for anxiety is the SCARED. And so I had talked about that with this provider and made sure that I included the SCARED and a scoring guide to assist with that. And then Dr. Coffey, for your considerations, do you want to touch on that piece?
No, that's great. And agree. I think what we try to do too is give some options, right? Because it's not uncommon that folks might be calling us on their administrative time. And I think, Christina, kind of previous ones will mention a few different kind of therapists that might be there, but also for medication options too. I think this gives some kind of tools and things in the back pocket to kind of pull from that if we like perhaps revisit the guanfacine, but that doesn't work, then we can try something else. And so we're not going to be exhaustive with all the options that are there because we really want to tailor it to the provider, but certainly just make sure that there are some options to try with the family. And would agree. I think what I'd offer to you all too. So I'm a child psychiatrist, but also an adult psychiatrist, and in my kind of newer role, I had to step back into adult psychiatry. I am such awe of our family medicine, of our pediatricians, of our primary care providers that are having to keep this all in their head. Because I know for me, when I was really focusing on child psychiatry for 5-6 years and then had to jump back into adult psychiatry, I had to relearn quite a bit. And so our hope is that we're kind of distilling the information for our primary care providers, because we know that the psychiatric disease states aren't the only thing that are coming into primary care. We know that there's respiratory illnesses, screening for, cardiovascular issues, cancers, and other things that are presenting to the primary care office. What we really want to do is kind of distill that information in a really high yield way for our providers to make sure that they're having that kind of best next step forward. The other thing I'd offer too is I think that in connections with us, we're at OSU, we have an outpatient child psychiatry clinic. We really try to make sure that we're keeping kids in the primary care setting, but there certainly are some times that it might be like, listen, we've done step 1, 2, 3, 4, and 5, and we're still not where we want to be. It kind of allows us a place potentially to kind of triage and get people seen within our CAP clinic if it feels like we're not able to meet the need in the primary care setting.
All right, thank you, Dr. Coffey. And I just want to click back to this slide as we're wrapping up. We've got just a couple minutes left. So this is our information. This is how to reach us. Phone number, our hours. That QR code again takes you straight to our website. You can register there. You can access any of our resources there, including our learning library, any past trainings that we've done. And I want to give one plug that I forgot to give earlier. I think Raquel has already put something in the chat about it. We do trainings out in the community. We call them house calls. We will make a house call to bring a training to any location within the state. We've gone all the way out to the Panhandle and provided in-person training. All of our trainings are approved for CME and CEU credits. And so if you would like for us to come out to where you serve your patients, then Raquel has put our house calls flyer in the chat. You can also access that information from our website. It's no cost. We would be thrilled to bring a training to your location.
Yeah, we love a road trip. So let us know. We're happy to go out there, but we're also happy to do it virtual and just really appreciate all the great work that you guys are doing. Let us know how we can help.
All right. And I don't know if there were any questions that had come in, but if we want to take like the last 2 minutes, if we had anyone who had any questions.
I haven't seen any questions come in the chat yet, but feel free to unmute your line and ask a question. While everyone's thinking about a question, I did download and save all of the attachments from the chat and the links. So I will, when we send out this recording, I will include all those attachments and the links. So everyone will have that information. We received a comment, great work, OKCAPMAP. So thank you guys for such a great presentation today. One last call for any questions. All right. Well, as you go back, share information with your providers or whomever. If you have any questions or concerns, please do not hesitate to reach out. And thank you guys. Thank you, Dr. Coffey and Christina. This was a great, informative presentation.
Thank you so much for having us. We enjoyed being here.